Hi, very good morning. A very good morning to everyone. A very warm welcome to all of you to Smiledge Dental Education. On behalf of Smiledge Dental Education, I, Dr. Priya Sharma, thank you for joining us today for this educational webinar. We are truly delighted to see such an enthusiastic participation from dental professionals across the country. Our vision is to be the leading center of dental excellence. Our mission is to redefine dental learning by delivering comprehensive hands-on training rooted in evidence-based science and real-world participation. We believe that continuing dental education should not be just a theory topic, but about real chairside solutions that improve patient outcomes and make clinical practice more confident and predictable. So today's topic is one such area that every clinician encounters at some point: taming the endodontic flare-ups. Endodontic flare-ups can turn even a well-planned root canal procedure into an unexpected emergency, causing discomfort for the patient and stress for the clinician. Understanding why flare-up occurs, how to prevent them, and how to manage them effectively is crucial for predictable endodontic success. We are honored here to have with us today Dr. Lochan Khullar as a speaker. Dr. Lochan, she's a passionate clinician, researcher, and educator in the field of conservative dentistry and endodontics. She completed her Bachelor of Dental Surgery and Master of Dental Sciences from Manipal College of Dental Sciences, Mahe, graduating with distinction throughout her academic journey. During her studies, she received multiple awards: the ISPRP Distinction Award for achieving the highest marks in her master's examination, and the Abhinash Naha Memorial Volunteer Services Award for her exemplary contribution during her studentship. Her clinical expertise includes advanced endodontic and restorative procedures, complex retreatments, and aesthetic rehabilitations. Alongside clinical practice, Dr. Khullar actively contributes to dental education by conducting lectures and hands-on workshops on molar endodontics and rotary endodontics, empowering young dentists with skill-based, evidence-driven training. Dr. Khullar's research has been published in reputable journals, including the Journal of Applied Oral Science, Asia Pacific Journal of Health Management and Endodontology. She has presented her work at national and international platforms, including the IFEA World Endodontic Congress, and was recognized with the FAMDent Excellence in Dentistry Special Jury Award, PG Student of the Year 2024. She continues to enhance her professional knowledge through global certifications, including courses from Harvard Medical School on stem cell medicine and ADEA on cannabis use in dentistry, reflecting her commitment to continuous learning and interdisciplinary growth. We welcome you, Dr. Lochan. Before we begin, a quick note for all participants. Kindly keep your microphones on mute during the session. You can post your questions in the chat box and we will be taking them during the discussion in the Q&A segment, which will be the last segment of this webinar. Over to you, Dr. Lochan.
Good morning, everyone. Thank you so much, Dr. Priya, for that lovely introduction. I'm very humbled. And welcome to the audience for waking up early in the morning on a Sunday. And I hope you have your coffees in your hand and your notepads to go ahead with this webinar. Daily routine endodontics. And without much ado, let's begin. So, as I said, that today is a Sunday morning, and if you are residing in the northern part of the country, it is pretty chilly out here. So, kudos to all of you for waking up and joining it. Let's take a situation, and I'm sure you must have encountered this situation a couple of times at least. You are getting ready to go to your practice, and you get a call from the receptionist saying that a patient whom you treated the day before has called up and is complaining of severe pain in the same tooth that you had treated the day before. What will be your reaction? Well, I'm sure annoyance is first because you are pretty flabbergasted that why is the patient calling? Because that patient was completely asymptomatic when you had started the treatment. So yes, that will lead us to think that this is might be a classical case of a flare-up. So how do you manage such patients? What are the certain tips and tricks which you can keep in mind while beginning such a tooth or such a case, which will prevent you from encountering such a situation where the discomfort is not only caused to the patient but also to you? So, with this, welcome you all to the webinar Taming the Flare Smart Endo Strategies. Before we dive into how to manage it or how to go about preventing it, we first need to quickly rewind and revise of about what is a flare up, how does it happen, and importantly, why are we talking about it? So now let's quickly talk about what is a flare up. As we all know, it's an acute exasperation of pulpal or periapical pathology. Definitely, it's acute in nature. It's not something that is chronic. It's not something that the patient will say that I had a lingering sort of a symptom or a lingering pain which was mild in nature. No. This is your first indication that it might not be a true flare up. So, it is an acute exasperation of a pulpal or a periapical pathology. It occurs within hours to days following the endo treatment. Again, a very important point to keep in mind. It occurs within hours. Like example, if you started the treatment or the RCT or root canal treatment maybe in your morning session, by evening or maximum by the next day, the patient will call up and tell you about the symptoms if in case it is a true flare up. Also, sometimes what happens after you've completed your root canal treatment, patient might just call up the next morning itself saying that patient is having an unbearable kind of a pain. That again qualifies as a flare up. It is characterized by pain, swelling, or sometimes even both, and requires an unscheduled visit. So, yes, you cannot ask the patient to wait it out and it will slowly reside on its own. No, it will not resolve. So, you need to see the patient on an urgent basis. So the key point here is not all post-treatment discomfort qualifies as a flare-up. True flares interfere with the daily function. Now we've seen what is a flare-up. Let's quickly see how does it happen. We all know that in our university days, we read quite a bit on flare-ups, the scientific theories behind it, how does it happen. But today, right now, I will just tell you about those practical points of how does it happen so that you're able to prevent them in your routine practice. The first and the foremost, microbial factors, of course. These pathogenic bacteria, which specifically include P. endodontalis, gingivalis, and the Prevotella species, have been found in flare up cases a lot. So, what happens? We all read about or we all know about the local adaptation syndrome. Let me just give you an example for this. Imagine there are two families living in a house, family A and family B. They are in quite a harmony. They live comfortably together. Now, if family A has a little tiff with the neighbors, do you think the relationship between family A and family B will slightly get affected by it? Well, that's right. It's exactly what happens. Imagine the host immunity or our immunity as family A and the pathogens or the bacteria as family B. As soon as we instrument or as soon as we start our root canal treatment, what happens is the family that's residing around the neighborhood or that has a tiff with the neighborhood, which in this case are the pathogens or the bacteria, they start getting affected. And in a way, it starts affecting the relationship or that comfortable position in which the host immunity and the bacteria were living around the apical area of the tooth starts getting affected. And due to this disruption in the local adaptation syndrome, a flare up occurs or the symptoms start. Next, we have the host response. Again, individual immunity reactivity. We all know everybody has a very unique biological makeup, so it's pretty difficult to predict if that particular case, having said that other risk factors are taken care of, will or will not go for a flare up. Having said that, there are certain factors which predispose the patient or the tooth for a flare up. Pre-existing periapical pathology. Definitely, if there is already a presence of a periapical pathology, there are higher chances that that particular tooth might lead to a flare up. So always keep in mind whenever you're taking your preoperative radiographs or you're evaluating the tooth clinically, you need to be sure that if there's a pre-existing periapical pathology, just take the preventive measures or just be careful while doing that particular case or that particular performing an endodontic treatment in that particular tooth so that it does not lead to any further symptoms. Systemic conditions. Well, of course, there have been enough studies on the fact that diabetes or diabetic patients are more prone to flare ups. Apart from that, patients who are systemically compromised, for example, immunocompromised patients, do have a higher chance of going for a flare up. And finally, we all read about it day in and day out. The root cause of every problem in our life is stress. So, how can the dentist leave behind? Yes, the stress levels. If you see a patient who is undergoing extensive stress in life, or in general has some stressful conditions happening around him or her, that particular patient might end up to your clinic saying that he or she is having severe symptoms as soon as you start the treatment, saying that this particular case has gone for a flare up. And finally, talking about the elephant in the room, procedural errors. Well, over instrumentation. I think there has been said enough about it, and we have practically seen it. As soon as we do an over instrumentation, or we take our instruments beyond the apex, or we violate our working lengths, there are extremely high chances that that tooth will go for a flare up. And as we have talked and read much about over instrumentation, equally important is an inadequate canal debridement. Of course, while doing a root canal treatment, if we are not maintaining asepsis, that particular tooth is said and bound to go for a flare up. There will definitely be a reaction from the pathogens if you're not clearing it out well. Next is missed canals. Of course, if we have not evaluated the internal anatomy well while beginning the procedure, in case we have not evaluated if might be an extra root or an extra canal in that particular tooth, that particular untouched pulpal tissue will definitely give you symptoms. And finally, inadequate intracanal medicament. This again is an interesting topic. We'll read or we'll talk further about it in the further slides. Now we have seen the what and we have seen the how. Finally, let's talk about why. Why are we talking about it? What's so special about flare ups? Well, according to literature, flare up rates between 2 to 20% of your overall cases, obviously depending on the case complexity, which is the internal anatomy, and the technique used. So, yes, this would mean that approximately 1/4 to 1/5 of your cases might end up in a flare up. So, yes, if you're treating 5 patients in a day, that one patient might come back and say that I'm having unbearable pain as well as swelling. Most of the flare ups occur within 48 to 72 hours. Why is that important? Now imagine it's not something chronic, it's not something that you treat today, and the patient will come back after a week or 10 days or 15 days saying that, okay, I'm having a little discomfort. No, it is an immediate reaction. The body immediately reacts. That means we as dentists need to be in a position to immediately come with a resolution for the patient's problem. So as soon as we are done with our treatment, we need to keep in mind if it's going for flare-ups, what preventive measures we should take. How can we prevent it from happening? Next, oh yes, this is again a very important point. It can become a pretty embarrassing situation for the dentist, especially if the tooth that you treated was previously asymptomatic. What do the patients commonly say? Doctor, when I came to you, I was completely fine. I just had a little bit problem of food lodgement. And as soon as you touched the tooth, I am having unbearable pain. I am unable to sleep. Now imagine how would that look? The patient or any human being comes to a doctor for the resolution of their pain or the resolution of their symptoms, not to enter another set of symptoms, right? So I think all these three factors are good enough and justify why we need to take our flare up seriously and how we can prevent. So we have seen what, how, and why of the flare ups. Let's talk about the resolution. So much about the problem, we need to talk about the solution, right? So let's resolve it. The 3D approach. Now, this is something that I came across and I routinely implement in my practice, and it is something that is very easily approachable. The 3D approach. So, the 3Ds stand for diagnosis, definite treatment, and drugs. So, let's see what each of them stand for and how we go about treating the patient. The first one is correct diagnosis. As we have already seen, flare ups are an acute exacerbation of pulpal or periapical pathology. It is very important for us to correctly diagnose a flare up because only then will we be able to successfully manage it. In case we misdiagnose or we're not able to understand what's happening with the patient, managing of it becomes really difficult. And as I have told you, if it's the case where the patient was previously asymptomatic and asymptomatic, you not only have to deal with the technical part of it, but also reassure the patient. And that in itself becomes a different job. So, yes, correct diagnosis is essential. Again, we always need to keep in mind that it is an instant response or an immediate reaction. So it occurs within hours or days of initiation or continuation of RCT. This particular point holds good in cases where you're performing your root canal treatment in multiple sittings, not a single sitting RCT. Finally, it happens inter-appointment, that means in between your appointments, or it can happen post-operatively. In that case, in case of a single sitting RCT, post-operative flare-ups are also seen. Severe pain and swelling. These are two symptoms that the patient will definitely present with and are the indicators of a true flare-up. It definitely interferes with the daily routine. So, all these points, if kept in mind, will lead us to a correct diagnosis of a true flare up. Let's talk about the next D, the definite treatment. So, this consists of basically five aspects. Firstly, reinstrumentation, incision and drainage, intracanal medicament, occlusal reduction, and reassurance. We will see each of these in detail now. Reinstrumentation. This is the primary step. Whenever we see a flare up case, the first thing that pops in our heads is okay, let's quickly see what's wrong. Let's quickly re enter the access cavity. Let's quickly debride. Let's quickly irrigate. And then see how does the patient respond. So, yes, reinstrumentation consists of re entering the access cavity, re-evaluating the internal anatomy. Now, in order to do so, I urge you all that whenever you see a flare up case, just add those 10 extra minutes into your appointment. Maybe the first time when you had performed or made your access cavities, you had not completely given that much of time while performing the root canal treatment. So, when the patient comes back with symptoms, when there's a flare up, please, while entering the access cavity again, reevaluate, give it some time, look at the radiographs, study, examine. A lot of times, just giving that extra 5 to 10 minutes to reevaluate the internal anatomy gives you the solution to the flare up. And definitely, while doing so, it is always advised to do it under magnification and illumination. Even in cases if you do not have a dental operating microscope, use your simple dental loops. In case you don't have loops, just give those extra 10 minutes. Reevaluate whatever adjuncts you have, be it your radiographs. If needed, take a multiple angle radiograph so that you do not miss out on any extra root or any extra canal. After you have reevaluated, you have re entered, you are sure of what you found, you need to reconfirm your working length. Time and again, we have talked about the most valuable aspect of to treat a flare up is working length. Reconfirmation using apex locators or be it your digital radiography, whatever sails your boat, you need to pick that up. Going beyond the apex or be making it short of the apex are two not so ideal scenarios. Of course, while reconfirming the working length, you need to re-establish the patency as well. So what I do is, after I have re-entered, after I have reevaluated, while I'm confirming my working length, I do another round of cleaning and shaping. There is no harm. You can do that so that if there is any pus discharge or if there is any accumulation of any pathogens still present, that can be flushed out very easily. Having said that, thorough debridement and copious irrigation will help you a lot in such a case. So while re-instrumenting, you need to re-evaluate the internal anatomy, you need to reconfirm the working length, clean and shape while performing copious irrigation using your gold standard lovely hypochlorite. Sometimes what happens? The patient just doesn't complain of pain. They also complain of swelling. That can be a really difficult situation for the patient. So, in order to provide significant and emergency pain relief, incision and drainage can be done. What does it do? It relieves pressure and facilitates pus discharge if there is any. In case the patient, along with having dental symptoms, does also have systemic symptoms, it is not just localized to that particular tooth anymore, we need to prescribe antibiotics. However, if there are no systemic symptoms such as fever or lymphadenopathy, it is always advisable to avoid antibiotics. In jump to reinstrumentation or deobturation. Now, what does this mean? Never ever take as incision and drainage as the only option. You do that, you send the patient back, and you will tell the patient, okay, now everything is fine. You will not experience these symptoms. It is always advised that while you are performing incision and drainage, you should also re-instrument the canals. You should always deobturate in case you find something missing in your obturation earlier. So in those cases, it is best to deobturate and also perform incision and drainage if the case requires so. Now, after you have re-entered, re-evaluated, redone your cleaning and shaping with irrigation, let's talk about intracanal medicament. Intracanal steroids and antibiotics have shown a better pain relief according to literature. So the most commonly used intracanal medicament is our own very favorite, calcium hydroxide. But in case of flare-ups, it has been seen that a combination of steroid and antibiotic can help you out a lot. And this is something that I routinely practice as well. Your antibiotic steroids include your TAP, your DAP, and your corticosteroid intracanal medicaments include dexamethasone. And a combination of that, such as Ledomex, can actually help you out a lot in treating these patients with flare ups. Now, as I have already said, in case you're unable to acquire these particular intracanal medicaments, you can use your gold standard, your everyday calcium hydroxide paste. However, you can make a slight adjustment to that, a modification to that. If you use your calcium hydroxide powder with chlorhexidine, that has shown to be even more effective than just using your calcium hydroxide. Of course, after you've done all this, you need a reliable temporary restoration. Because if your temporary restoration does not stick or does not stay in the access cavity long enough, your intracanal medicament will just be useless. It won't be able to provide the effect that it is meant to. Secondly, there will be contamination of the canals again. There will again be a disruption in the local adaptation syndrome. So all the things that we have seen so far hold good only and only if you are able to place your temporary restoration well. Having said that, there was another very interesting article that I thought I'll share with you all. This study was performed by Hegde and workers, and it evaluated the use of calcium hydroxide when compared to other intracanal medicaments on the post-op pain. And this also showed us that calcium hydroxide, though extremely effective when treating flare up cases, is even more effective when it is combined with chlorhexidine. So you can take a screenshot of it. And if you wish to read a bit further on this particular article, you can definitely go ahead. Okay, let's talk about a very interesting topic and something very close to my heart, occlusal reduction. Now, this is something that I have been hearing from my university days. Whether or not it is advisable to perform an occlusal reduction or to not occlusally reduce. How should we go about it? Where should we choose? What should be our ideal option? So, yes, it is a very controversial topic. Having said that, what is occlusal reduction? It is a reduction of 1 mm to 2 mm of functional and non functional cusps, along with the marginal ridges. So, why so much of controversy around it? What does it help prevent? Why are we doing it in the first place? Well, the concept of mechanical allodynia. What is mechanical allodynia? The nociceptors that are present around the root apices, they get activated as soon as there's some mechanical stimulation on it. What does mechanical stimulation mean in this case? Whenever the patient chews, whenever the patient bites, what happens is there's a mechanical stimulation and the receptors get activated and they respond in form of pain. So that is mechanical allodynia. So the ones who support occlusal reduction say that in order to prevent this mechanical allodynia, it is advisable that you occlusally reduce the occlusal surface. But is it advisable? Let's see what the literature says. Now, occlusal reduction has shown positive results. It has shown pain relief, especially in cases of irreversible pulpitis with symptomatic apical periodontitis. That means if the patient comes to you with a preoperative pain, in such cases, performing an occlusal reduction helps you. Secondly, there has also been some comparisons. If, like, after how much time or after how much days post-operatively does occlusal reduction actually show its effectiveness? So it varies. There are multiple studies. Some of them, the ones done by Imara and workers, and the one done by Bilawi, this was in the year 2019. They have clearly stated that after a 12 hours period, post-operatively, occlusal reduction has said to be beneficial. Another study said that it was only beneficial after 72 hours, and one study even said that it's good after 6 days. So, again, there's a lot of controversy around it. But what I prefer is performing occlusal reduction, as we have already seen in literature, in cases where there is symptomatic apical periodontitis. Secondly, in case if you are going for a case that you know will take time, that means A, you are going ahead with a multi visit root canal treatment. B, you know you will end up taking a lot of appointments for your intracanal medicament change. So in these cases, what happens is if you, in the first appointment, do an occlusal reduction, what happens is by the time you do your obturation and by the time you are finally going ahead with a full coverage restoration, which in this case is crown, the indental clearance starts reducing a lot. Why does that happen? Because of an opposing tooth that slowly starts supra-erupting. So at the end of the treatment, when you're finally sitting down and performing your crown prep, you need to reduce the tooth a lot because initially you had already reduced 1 to 2 mm. So I feel that's my personal experience that it is advisable in cases where you know it's going to take time, where you know you are going to give a prosthodontic rehabilitation after maybe say a week or 10 days. It is advisable to not go ahead with occlusal reduction there. So, where should we actually reduce? Especially in cases where the enamel is undermined. One or more walls of the tooth, maybe because of the decay, is undermined. So, in those cases, it is very easy for the tooth to fracture due to the biting forces. So, over there, it's actually beneficial to go ahead with occlusal reduction. Secondly, if you think that that particular tooth will go for a full coverage restoration, not a tabletop, not your onlay, not your overlay, not your vonlay. No. If it's going for a full coverage restoration, yes, in those cases, it is advisable to go for an occlusal reduction. So these were some strategies which I adapt while deciding if I should or should not go for a occlusal reduction in a particular case. Again, the literature. There were a couple of interesting articles uh, that I go through whenever I'm in doubt. So I thought I'll share it with you as well. You can take a screenshot and maybe refer to these articles in the future. So the first one was by Shams the Day, and it is a systematic review and a meta-analysis where again this highly burning question has been answered: does occlusal reduction reduce post-endo pain? And again, in this particular article, we saw that the significant effect was felt up to only about 2 days. So again, there was a not a clear distinction of how many days or how many hours we should wait for it to show its effect. Now, second very interesting article published in 2025, this year itself. There, Alma and workers, they compared the effect of cryotherapy versus occlusal reduction. So what are they doing? They basically comparing these two procedures. Because, firstly, again, is there any other way apart from occlusal reduction where we can go about reducing the post-op pain? So they have introduced the process of cryotherapy. Again, here among the study groups, they saw that cryotherapy definitely reduced post-op pain. Second number was occlusal reduction. However, when the cases where occlusal reduction was done versus the cases where it was not done, among these two, the cases where occlusal reduction was done definitely showed a lesser post-op pain. So again, this is another article, very interesting one. You can go ahead and read it if in case you want to know more about occlusal reduction. Apart from that, there have been studies by Belavi, Imara. Those are again extremely interesting studies to read. You can go ahead and read those as well. Okay, so we have covered the four aspects of definite treatment, which included reinstrumentation, incision and drainage, intracanal medicament placement, occlusal reduction, and let's talk a little bit about reassurance. So, why is that even a aspect of the treatment protocol of flare-up? Well, I feel the most daunting experience of a human being is pain. So, as soon as the patient walks into your clinic with pain, they have only one thing in mind, that the doctor needs to relieve my pain, or I have entered this clinic, or entered this hospital, or this practice with one definite goal for that particular sitting is to get resolution from pain. So, in a flare up, sometimes the opposite happens. A previously painless tooth becomes painful. So now you can realize the importance of reassurance. If we do not reassure our patients, trust me on this, sometimes we have done the best treatment in order to get the patient out of pain and still it persists. So, reassurance, if not present, our entire treatment might not get us the results that we are expecting from it. Hence, reassurance becomes a very important leg in this entire treatment protocol, even in cases of some preventive strategies. For example, talking personally, what I do with my patients is once I recognize that this particular patient or this particular case has a very high chance of turning into a flare up or going for a flare up due to numerous risk factors. For example, if it's a retreatment case or it's a case which already has a peribipial pathology, I already in my mind know that it might go for a flare up. It is always good, or I feel sometimes it's better to inform the patient during that appointment itself that, sir, ma'am, you might have pain. The tooth might respond. And you would be surprised, patients tend to understand this very well while they're on the dental chair. That, yes, okay, my tooth has been in a state of infection for a very long time. And now that the dentist is finally treating it, there might be pain. So you can use some analogies, you can use some different examples to give the patient, and it is very easy and very comfortable at that moment to make the patient understand that it might go for a flare up. It becomes easy for both you as a dentist and the patient if in case such a case actually happens. Coincidentally, yesterday itself, I had a patient who had an ongoing root canal treatment, and due to some medical emergencies, she could not turn up for her appointments for 2 months. So I had started her root canal treatment in October, and she was unable to report to the clinic due to medical emergency. She was on bed rest, and she finally reported yesterday. And then I had informed her in that same appointment that, ma'am, since there was a long absence of treatment for 2 months, there are extremely high chances that this case can and will give you some problem as soon as I retouch it. And imagine, she did have a flare up. I did not go beyond my working lengths. My temporary restoration was completely intact. There was no procedural error, intentionally or unintentionally, made by me. But I knew that the local adaptation syndrome that has developed very nicely in the past 2 months has finally been disrupted by me, which was the need for the treatment. So when the patient reported, she obviously was in pain, but she was in a state to understand what I had already told her, versus a patient for whom it's completely unexpected. So I prescribed her I did my 3D approach with that patient, and hopefully she will be very well tomorrow. All right, so let's go to the next D in my 3D approach. We've talked about diagnosis, we've talked about definite treatment, and finally, let's talk about drugs, the pharmacological aspect of managing flare ups. Pain management protocol. To manage flare ups, it is always advisable to go ahead with an analgesic. So, what is the first line analgesia? A combination therapy of ibuprofen, which can range from 200 to 800 milligrams, plus acetaminophen, which can again range from 325 to 1000 milligrams. Every 6 hours or every 8 hours provides superior relief when compared to either of them given alone. So I know as dentists, as practicing clinicians, we all have our preferred group of drugs, which in our clinical experience has shown to be very beneficial for patients. But however, studies have shown that when it comes to flare ups, slightly modifying your routine prescription or your routine preferred drugs, if you go ahead with a combination of brufen and paracetamol, it has shown extremely beneficial to reduce pain in flare up cases. Having said that, what I personally practice a lot is pre-operative medication. Again, cases where you know these might lead to a flare up or these might lead to discomfort for the patient. It might lead to your patient walking into your clinic unappointed, unscheduled visit. So, in those particular cases, it is always good, it is always best to go ahead with a pre operative medication. Elephant in the room, antibiotics. The dentists sadly have been accused of over prescribing or misusing antibiotics. So, the good news with respect to flare ups is it is only and only advised to go ahead and prescribe antibiotics in flare up cases where there are systemic symptoms present, such as a fever, lymphadenopathy, a diffuse swelling, or the patient has an immunocompromised status. Those are the cases where you will go ahead with an antibiotic prescription. Otherwise, your analgesia works just fine. And trust me on this, you do not need to prescribe antibiotics for flare ups. Only and only if there are systemic symptoms present. So, if you have to prescribe antibiotics, your first choice will be our very own, our favorite, amoxicillin 500 mg, 3 times a day for 5 days. And in case of active pus discharge, in case you suspect an anaerobic infection, go ahead with the metronidazole, 400 mg thrice a day. So, this particular regimen works extremely well when it comes to treating the systemic symptoms of antibiotics. All right, so we have done whatever we could on the dental chair. We have correctly diagnosed, we have done our treatment, we have managed our symptoms very well, and we have prescribed the patient for a pharmacological intervention. Now, follow up. Again, very important. Remember, the patient came to you with an unscheduled visit, so it was not appointed. So, it is your duty now to keep in mind to always follow up with this particular patient. So, what is the follow up strategy that I commonly implement? Ring the patient within 24 hours to check the progress. Very important. It not only shows that you know what you're doing and you know how and when and why the symptoms will subside, it also shows some sort of empathy towards the patient. You need to be empathetic and you need to show it. So it is always advisable to just tell your receptionist that you need to follow up with the patient within 24 hours of that appointment that was unscheduled. And it also gives you a head start. It gives you a heads up. Okay, what I did, was it right? Is it actually helping the patient? Or is the patient still in the same pain? What else do I need to do? Do I need to do something different? Should I call the patient again? So it is always, always good to call the patient within 24 hours, get that head start, and plan for your next appointment. So, in case everything is good, what you did worked out, your 3D approach is successful, you should appoint the patient again in the next 2 to 3 days. Maybe you could go ahead with the next step of your root canal, or you can go ahead with the prosthodontic rehabilitation, whichever step you're on. You can schedule this appointment in the next 2 to 3 days. Do not give a long gap because that might just lead to another set of complications. And finally, this is very important. You have to give extremely clear instructions to the patient of how and what to expect next, and the case where they need to urgently inform you if symptoms are going worse or how and when what they're experiencing. So, these 3 points is something that I always perform when it comes to my flare up cases. So you need to ring the patient, you need to check up on the patient within 24 hours, you need to schedule a review appointment or an appointment where you decide how to go about the next step in within 2 to 3 days. And finally, clear instructions and when to return urgently. Okay, we have read a lot, we have seen a lot, we have heard a lot about this particular quote: prevention is better than cure. Well, in case of flare up, trust me on this, I don't think I can relate anymore. Prevention is definitely better than curing a flare up. So, the certain preventive strategies which are very easy and you can easily implement those in your routine practice. Nothing hi fi, something very basic. This includes patient selection. You need to recognize before you touch the tooth, you need to know if this case will has the potential to turn into a flare up. So for that, you need to see if the patient is medically compromised, has acute infections, is a retreatment case, because all these cases are high risk cases, especially in the aspect where we talked about the host factors which affect flare up. Those can also qualify as high risk cases. So, in such a thing, you need to consider prophylactic measures. As I have already talked about, preemptive medication, prescribing medication before the treatment starts. And obviously, you need to spend a little bit more time in those appointments so that you don't unintentionally end up over instrumenting in an already case which is highly prone for a flare up. Okay? Working length. Definitely. We need to maintain the working length. We need to respect it. Do not over instrument. You can use your electronic apex locators. You can use your digital radiography, whatever sails your boat, whatever is good for you in your routine practice. But always and always remember to not over instrument unnecessarily. Irrigation protocol. Again, you cannot compromise on asepsis. So, using your copious sodium hypochlorite, gold standard disinfectant, with a gentle delivery. So always keep in mind, do not actively push your sodium hypochlorite. Sometimes I've seen when there is maybe the lesion is a little um, not so confined. What clinicians tend to do is use hypochlorite in a very reckless sort of a way, or in a way that, okay, as much as I push, with as much as pressure I push, it will lead to the elimination of all the pathogens. No, it's not like that. In fact, the active pushing of hypo might actually lead to other set of complications. So always be gentle with your hypochlorite. It's not that how much pressure you put, the pathogens will go out. It's nothing like that. So be gentle with it, and always use side vented needles so that you don't end up extruding the hypochlorite. And we've all um, heard about, talked about, read about your hypochlorite accidents. So we don't need something like that to happen. And these are just little things which, when we're performing our root canal treatment, we tend to overlook because we have bigger things in mind. What if, okay, this canals look like this, particular tooth might have an extra root. I understand all those things are important. But whatever you do regularly in your practice, sometimes we do it a little not so mindfully. So when you're treating cases which have a high risk of flare up, just be very mindful of these small, small things. Your working length, your irrigation, maybe the sealer that you're using. Just always remember whatever goes beyond the apex, intentionally or unintentionally, is a foreign body. Our body does not recognize it, be it your sealer, be it a biocompatible sealer, whichever sealer. I'm not saying with this sealer is better or that. Definitely, your bioactive, biocompatible sealers have shown less post op pain, but still they show pain, right? So whatever goes beyond the apex is still considered as a foreign body. So there has to be a counter reaction from the body's aspect as well. So your files, your irrigants, your intracanal medicaments, be it your sealers, try not to go beyond the apex until and unless the case demands for it. So it's better to always be mindful of these tiny little things. Again, I talked about intracanal medicament. In case you need to treat a patient which is currently undergoing a flare up, as we have talked, and the literature supports us, using calcium hydroxide with chlorhexidine is always extremely well when it comes to managing the post op pain. Apart from that, if you can use dexamethasone with chlorhexidine, amazing combination. I have seen some amazing results with that as well. So it's not always that you, if you do not have a, you can't treat, like if there are two things necessary, A and B, if you don't have A, then you can't treat the particular symptom or the particular problem or the disease. No, there's always an alternative. There are always enough and more literature about how you can just go about treating your patients and go about preventing these particular mishaps or these emergency cases, such as flare-ups, with the things that are present in your operatory. So you don't need to panic, or you don't need to get those extra things. Always take support of literature, get your evidence right, and I'm sure you will just be fine when it comes to managing these cases. So let's talk about some evidence-based takeaways. Again, as we have talked, the evidence strongly supports the use of combination analgesia. Brufen with paracetamol, it provides a good pain relief than either drug alone or opiates for post-endo pain. Next, preemptive dosage works. Oh yes, I can vouch for it. It does work. Administering your NSAIDs before treatment significantly reduces post-op pain, intensity, and the analgesic consumption. Next, antibiotics don't replace drainage. Oh, yes. So, as I mentioned earlier as well, Don't prescribe the patient and send the patient back saying that, okay, everything will be fine. No, it will not replace your handwork. It will not replace things which you mechanically do, right? So, mechanical drainage and source control remain the primary treatment. Antibiotics are just an adjunct, not curative. And that too in cases where there are systemic symptoms present. Working length matters. We have emphasized enough on it that maintaining your working length and gentle instrumentation techniques significantly reduces flare up incidence. Especially when we talk about cleaning and shaping, when you use your step back technique of cleaning and shaping, or when you're just using your hand files to negotiate that canal, there has been a lot of literature on it that tends to push the debris more apically when compared to your crown down technique. So again, that is another area where you can predict if you're using your step back or the kind of cleaning and shaping you're using. You can predict that, okay, this, because I have used this particular uh, type of cleaning and shaping procedure versus the other one, it can lead to a flare up. So again, all these things matter, and most flare ups resolve with conservative care. Trust me on this. Your 50% job is the work that you do in the patient's mouth, and 50% is reassurance. So, if you're able to reassure the patient well, oh, yes, the flare ups do resolve with conservative care. So, the majority of post treatment flare ups resolve within 48 to 72 hours with appropriate analgesia and reassurance. So, yes, reassurance is extremely important. Okay, so whatever strategies we discussed today, whatever strategies or new advancements that you read about, it is always good to have literature backup to it. For that, you need to have a foundation. So, I came across these lovely research articles for in order for you to build a very strong foundation when it comes to flare-ups. So this one was by Sequeira and Barnett. I think this is one of the landmark articles in Flare Ups. This was published way back in 2004, and it beautifully explains mechanisms, diagnosis, and treatment of interappointment pain. It talks at length about these particular aspects, and it is a very good article to have a great foundation on flare ups. Once you've built your foundation, you need to have a strong evidence as well to it. So, another very interesting read, an update on endodontic flare ups. This was published in 2021 in Saudi Dental Journal, done by Bassaman workers. Again, this talks at length about what are the recent advances, the kind of risk factors that takes place that lead or are more prone to flare-ups. Again, a very interesting read. I enjoyed reading this research study a lot, so maybe you can have a look at it as well. And finally, be aware of risks. So you can only prevent if you know. And for you to know, you need to know the risk factors. You need to know the cases which are more prone to flare ups versus the others. So, for that, again, very interesting. I would call it an interesting research study by Axoy. He talked about the top risk factors for endo flare up, and uh, he basically had the periapical lesion or the periapical pre-existing periapical pathology as the number one most sensitive risk factor. This was followed by preoperative pain, and next was multiple visit treatment. So that again can lead to high risk of flare-ups. However, in this particular study, retreatment, female gender, basically gender bias, necrotic teeth, and analgesics was not so it was not so sensitive when it comes to flare-ups. So again, this is something that a part of it I agree with, and a part of it not. So I feel the risk factors which were down below in the list, they still hold some controversy. They still have some controversy attached to it. So this is something that we can maybe read more upon. But I still feel that cases which are for retreatment, which have already been treated and you're retreating them, because it's not just about evidence, it's something about the clinical experience also that we have while performing patients. So retreatment definitely should be high on the list. But again, there are always bias present when it comes to research studies, and we can definitely read more upon it. However, it's a very well written and a very informative research article. So definitely you can have a look at that maybe in future. And with that, I am really glad and thankful for all of you to be attending this webinar. And I know it's a Sunday morning, so I understand you waking up in the morning for not for your flare-up case, but for a webinar on flare-ups. That really you deserve a pat on your back. And I would like to thank our organizers, Smiledge, Dr. Akanksha, Dr. Priya, for organizing this wonderful event, Core team, for your support. And finally, thank you all. Thank you all, the participants, for having this beautiful discussion with me on flare ups. Thank you.
Thank you, Doctor, for the excellent presentation. We'll now begin our Q&A session. Kindly post your questions in the chat here, and we'll address as many as possible one by one. And we are also live on YouTube. So the YouTube link has been shared in the chat as well. Please share, please subscribe to our channel. And you can also drop your questions on the live chat at the YouTube as well. You may go ahead with posting the questions if you have any. Hi, Vidushi. So your question is to Dr. Lochan is please shed more light on the occlusion reduction. Dr. Lochan?
Hmm. Yes, thank you so much, Dr. Vidushi, for that wonderful question. As I've already said, occlusion reduction is one of the very interesting topics close to my heart. I have been reading about it quite a bit since my university days. So I'll tell you what, since it's highly controversial, you will find evidence both in favor of occlusion reduction and not in favor of it. What I personally choose to do or to decide when and when not I should go for occlusion reduction, I do not come from a school of thought that completely rejects it or completely accepts it. It's completely case based for me. So when it comes to cases where as I've already discussed, cases which are already have undermined tooth structure or undermined enamel due to the decay, absence of 2 to 3 walls, the tooth is that means basically already compromised. In those cases, I do go ahead with occlusal reduction because I do not want my tooth to fracture while I am performing my root canal treatment. So when I talk about occlusion reduction, I talk about multiple visit unless I speak otherwise. So this is one factor which definitely requires occlusion reduction for me. And the next one is when I'm planning for a full coverage restoration, which is your usual grounds, right? In case when I want to go with overlays or tabletop restorations, I avoid occlusal reduction. I don't go ahead with that because, secondly, in cases where high risk cases of flare ups, or when I see that this particular case is slowly developing into a flare up, I go ahead with occlusal reduction. So these are 2 to 3 aspects where I definitely accept occlusal reduction. When do I not? As I said, if I know my particular tooth completion till obturation is going to take a lot of time, it's going to take some good amount of days, I do not go ahead with occlusal reduction. So those are the cases where I usually avoid it. Apart from that, in my routine practice, I do not reduce my teeth occlusally until and unless, as I stated, those three, four factors, I experience that, only then do I go ahead with it. Yeah, I hope that answers your question.
Okay, the next question, doctor. Um, any specific instructions to be followed when dealing with immature teeth in pediatric patients?
Yeah, so talking about flare-ups, what I have gone through the evidence and the literature, it mostly dealt with permanent teeth. However, when talking about pediatrics, or maybe if I talk about young permanent teeth, again, if I feel that those particular teeth are something what happens in young permanent teeth. There's a mixed dentition with which has deciduous as well as permanent teeth present. So in those cases, if I feel the particular tooth is out of alignment, what happens is if they're out of alignment, they experience more pressure. Some young patients have such a bite where the pressure is uneven. It's not uniform. Since all the teeth have not yet erupted, or there may be teeth which are out of alignment. So in those cases where we are expecting that an unnecessary extra force will be applied, in those cases, it is advisable to go ahead and think that this particular tooth might lead to a flare up and pick up the preventive strategies as usual. Secondly, in immature teeth, since it's an open apex, getting or taking your working length becomes a little tricky. So you need to be extra careful while getting the working length right. And again, be it immature teeth, be it permanent teeth, never ever violate the apex, never ever disrespect the apex, as I always say. So the same rules apply when it comes to permanent. Just that you need to be an extra careful because there are higher chances of your instrument going beyond. So at that moment, when you're dealing with the cleaning and shaping part of it, working length part of it, you just need to be extra cautious. I hope that answers.
Okay, thank you, doctor. The next question is for how long should we place an intracanal medicament in a flare-up case?
All right. So thank you again for your question. How long should we place an intracanal medicament? Okay, so very interesting. As I've already told, that your intracanal medicaments, be it your calcium hydroxide, can maximum be placed in your canal for 7 days. That's your normal protocol. When it comes to flare ups, again, just to revise what is a flare up, it happens within hours to a couple of days. So, maximum 48 hours, 72 hours. For example, patient came to you the next day, say between 24 hours to 48 hours, right? You have placed your intracanal medicament. After 2 to 3 days, when you recall the patient, symptoms have subsided, patient has taken his analgesics, flare ups is over, you can definitely move on to your next step, which can be obturation or which can be your usual prosthetic rehab. If it's a case of single sitting and you have performed your obturation well without any aspects missing out on it, that means haven't deobturated. So I would say, Mac, you can wait after this flare-up symptoms have subsided. You can wait for maximum 72 hours, and then you can go ahead with your usual next step in the treatment. I hope that answers.
Okay, the next one. Are flare-ups more common in vital or non-vital cases?
Okay, that's something that's again very interesting. Thank you so much for whoever answered that question. So I remember our textbooks clearly state that whenever it's a vital tooth, that is more prone for a flare up when compared to a necrotic tooth. So I'm not fully convinced with that particular fact. Having said that, um, when you look at the literature, when you look at case studies or reports, it's very controversial. Some studies support the fact that necrotic teeth are more prone to flare ups, while some say it's the vital teeth. What I have realized over a period of time is necrotic teeth. This is my personal experience, have a slightly high predilection towards flare-ups when it compares to vital. It is not something that I have. It's not something that's mentioned in the textbooks. It's completely my clinical experience that I'm talking about. Because what happens is when it comes to necrotic teeth, I believe that the local adaptation response over there is pretty good. Like it's necrosed, bacteria is living there ha- very comfortably, and the immunity has again the part of our host immunity is again very comfortably adapted to that. So in case of a necrosed teeth, when you go about disturbing that LAS or a local adaptation response, chances of it becoming a flare up are a little high. That's what I have seen. Secondly, irreversible pulpitis with symptomatic AP, apathic endodontitis. So that again has a higher chance of developing into a flare up. So having said that, I believe vital teeth can have a chance. But again, if I want to open our evidence and check for literature, I find controversial results. Like I find studies which say the necrosed teeth are more prone to flare-ups versus vital teeth. Again, so I feel this is something that again we need to uh, keep in mind that flare-ups are multifactorial, right? So it's not just about necrosed teeth or vital teeth. Maybe in the cases that I saw, there were some other factors, that also led to that conclusion for me. So it's multifactorial. We can't always blame one particular factor for a flare up. It's an umbrella where a lot of factors exist. So yeah, okay. But do let me know if you believe that vital in your clinical practice has shown more flare ups versus the necrost or vice versa. Yeah, I hope that answers.
Uh, Next question. Please brief on intracanal medicament if possible.
All right. Intracanal medicament. Well, again, there's a lot of literature on it saying which intracanal medicament has shown good relief in the post-op pain versus which has not. So let's start with what the literature says. Literature says that a combination of antibiotic and steroidal intracanal medicament, most common example Ledmex, has shown the best results when it comes to relieving the post-op pain versus your antibiotic in ICM alone and your steroidal ICM alone, which is DEXA. These two have also individually shown pretty acceptable results. Also, DEXA in combination with chlorhexidine has shown to have better results when compared to DEXA alone, steroidal alone, right? Apart from that, when it comes to our most commonly used calcium hydroxide, works just right when compared to no ICM at all. Also, if you want your calcium hydroxide to be even more effective, if you mix it with chlorhexidine, it has again shown some really good results. So, yeah, I would say if you have access in your clinic or your practice to a combination of antibiotic and steroid, the best. If not, go ahead with your normal calcium hydroxide, but instead just take adjunct of chlorhexidine with it. That should suffice. I hope that answers.
Yes. So the next question is in the Q&A box. I would please request everyone to drop their questions in the chat box as well as in the Q&A box. So, doctor, in your experience, when the pain improves after re-instrumentation or occlusal reduction during a flare-up, but there are no clear signs of infection or an abscess, as a clinician, how do you decide whether to intervene again or we can simply observe and reassure? In other words, how to avoid the choice of risking over the treatment when the end of flare-up is purely patient stress-based? Should I repeat this question?
Yeah, I think maybe in parts we can
Okay.
talk about it.
So, in your experience, when the pain improves after re-instrumentation or occlusal reduction during a flare-up, but there are no clear signs of infection or an abscess, as a clinician, How do you decide whether to intervene again, or we can simply observe and reassure? In other words, how to avoid the choice of risking over the treatment when the endo flare-up is purely patient stress-based.
All right. So, from what I have understood from this lengthy question, well, firstly, thank you so much for asking this question, Doctor. Uh, I think this is something that we tend to experience once in a while in our practice because we see that nothing is wrong, everything is well in the tooth, there is no infection, there is no re-instrumentation, everything is perfectly fine. Still, patient is having symptoms. So, what I would recommend is, firstly, always and always think as stress as the last risk factor when it comes to flare ups. Do not, at the first instinct, go with, okay, this patient seems stressful, or maybe this it's the best, the most common phrase that we use is maybe it's psychological that the patient is having this flare up, and hence there's nothing wrong with our treatment. What happens is sometimes when you open the tooth up again, when you re enter the axis, just doing a very good cleaning and shaping, re-cleaning and shaping, or maybe just because sometimes there is still some pathogens present near, maybe near that isthmus area, or maybe near some complex internal anatomy, which where we have technically tried to reach using our files, but we haven't. So in those cases, your chemical irrigation or your chemical part of your BMP or the CMP works really well. So, because even I have experienced this, that we have done everything right and we have even done our re-instrumentation, still things don't work out. What happens is stress definitely is a factor, but it cannot be the only factor, is what I'm trying to say here. Definitely, if there is 10% pain, patient will experience 50% because of stress, or maybe 20% because of stress. Understandable. But as a clinician, what your job is to treat that 10% because that is in your hands. The stress part of it is not is in patient's hand, right? So in that case, reassurance becomes even more better, even more, it holds more value than the technical part of it. So, in such a case, just focus on your chemical irrigation, focus on using that disinfectant really well. Use your irrigant activation systems, use your side vented needles. Just giving a good round of hypochlorite, it works wonders. So, especially in cases where your files can't reach, but your irrigant does. So, over there, because see, radiographs are 2D. If you take a CBCT, it's 3D. I understand. But still, there are some nuances here and there in the tooth, in the root canal. I remember back in university, my very lovely professor used to say that when you compare the apex of the tooth, what does it look like? It looks like a banyan tree. So many branches and so many roots coming out, and it's basically highly complex. And what do we see in our radiograph? Just an opening, right? Just to the apical foramen. Sometimes even that not. So what I'm trying to say is a lot of times there are a lot of things which we can't see end of the day because it's a micro procedure. So always try to put stress way down in the list of why things are not working out, okay? And even if it's a point that does affect your treatment, that is something, it's a part of it, not the whole story. So always focus more on irrigation part of it. That's what I believe in. I hope that answers.
Okay, please brief on excessive pushing of calcium hydroxide in periapical abscess cases. Does it cause any problem or is it safe?
Thank you so much for your question. And something again, which we very commonly see in our day to day practice. And again, talking about literature, I have read uh, articles where they support pushing it beyond versus articles where they do not. So again, I would put this into the under the controversial category. However, what I have realized is, sometimes it's very similar to the concept of ceramic or bioactive sealers nowadays. That also, if a bit of it, like the concept of the apical puff, if it goes beyond the apex, it's actually wonderful. Very similar to that particular concept. So what I'm trying to say is that calcium hydroxide, though maybe I would say in 80% of my cases, I have not seen a significant symptom occurring because of that, of pushing calcium hydroxide beyond. Having said that, foundationally, I come from a school of thought that anything that goes beyond the apex is foreign body. The body will react, end of story. So that's something that I always keep in mind. And on top of that, I build my evidence, as we have seen in our slides also, right? The foundation is that whatever goes beyond is foreign body. So some cases I understand pushing it beyond actually helps, and I'm not saying that I never do it. As I said, 80% of my cases in which there has to be the apical foramen or the apical constriction is destroyed enough that as soon as you insert your calcium hydroxide, it goes beyond the apex. It actually has shown good results. It has actually shown healed part of the apex. So again, I would not comment, I would not directly accept or reject this particular school of thought. But again, I have also seen some severe cases where, in fact, tooth had to be extracted because of extrusion of intracanal medicament, which was calcium hydroxide. So again, you need to be very cautious and very mindful, even if you choose in your head to go beyond the apex, because always remember, it's going beyond the apex. You have no control over it. It might lead to a reaction. And for that, you need to keep in mind the risk factors before choosing which case to go for a beyond and which case to not. So again, because if it goes beyond and if it leads to severe swelling infection, I have actually seen such a case, and that patient ultimately got the tooth, extracted. So again, it totally depends case to case, and as and when you keep on doing your root canal treatments, ultimately, what I would suggest is it is never my intention to push the calcium hydroxide beyond. What happens is, due to infection, due to root resorption, what happens is the root apices or the root apex is already pretty resorbed. It acts as an open apex, if I might say, if it's right to say that. So ultimately, it does go beyond. And what it does is, it stays there and it helps in better bactericidal effect as the pH changes. So that is a good part of it. But intentionally, I have never tried to push it beyond. What if it's happening because of a destroyed apex? That is a different story. But yes, I do not intentionally never, because once or twice I've seen such a case where patient had really unpleasant experience. So yeah, that's what I have so far gathered in my experience. I hope that answers.
Okay. So, in case of calcium hydroxide and chlorhexidine intracanal medicaments, can chlorhexidine cause staining of teeth if used as intracanal medicament?
Yeah. Thank you so much for your question, and a very interesting one. However, both aspects. In literature, I haven't come across significant studies saying that it leads to staining. And second, in my clinical experience, I have very commonly and very often used a combination of calcium hydroxide and chlorhex, and it does not lead to staining. Secondly, the staining part of it, which might be coming in with a backdrop of chlorhexidine mouthwash, let me tell you, the percentages are totally different. So it does not, it's very highly compatible with calcium hydroxide and also with DEXA. So the part where staining happens, it has not occurred in my clinical experience. I hope that answers.
Okay. So, the next question. Should cases be retreated if a flare-up occurs after single visit RCT obturation, or should they be managed with medication and observation?
Okay, thank you so much. Very good question. Okay, when will you decide? Basically, the main question is if whether or not you should deobturate. Again, um, for this to decide, you need to be very clear in your head if it is a true flare up or not. Single sitting RCTs, um, after maybe a few hours or maybe after a day, if the patient says, I have continuous pain and it's not going away and it's severe, basically gives you symptoms of of a flare up. I I believe you should deobturate. Yes, I believe you should. However, a lot of times patients are not able to understand the difference between pain and discomfort. So if you believe, like that's for you to decide. You are the judge over there. If you believe it's just um, a discomfort, post-op discomfort, no need to deobturate. Also, for you to be sure that you don't want to deobturate, you need to be extremely confident in your root canal treatment. You know there is no way that you have missed out some extra internal anatomical structure, or you have not irrigated well, or there's still some pulpal tissue remaining. No, these doubts should not even crop up in your head. You need to be absolutely confident that nothing is wrong, and only then can you make this decision of not deobturating. If you have slightest of doubt, it's better to deobturate. Having said that, what I usually do whenever I'm performing a single sitting root canal, I always give analgesics. I always give a post-op prescription of my analgesics because I know intervention has been done. Patient can experience pain or discomfort. So what I do is I give a 3-day analgesic course. That is something that I have, practiced, and I have finally accommodated in my practice that this works the best for me. In case of single sitting, what I do is give a 3-day analgesic combination twice daily. So I give analgesics, anti-inflammatory, twice daily for 3 days. And trust me on this, 99% of my single sitting RCs, they never come back with a flare up. Having said that, I am of course very confident in my root canal. If yes, I have missed a canal or something like that has happened, and I have not done my observation well, I have not done my irrigation part of it well, then definitely it's always advisable to correct your mistake, because the first rule of Hippocratic Oath is to do no harm if you can't do any good, right? So this is something that you can always keep in mind. Try giving a post-op prescription of 3 days. Still, if the patient says yes, there's something, or if the patient is having it and still is having pain, then you know something has gone wrong somewhere and you need to reopt. Yep, I think that answers.
Okay. What is the ideal way to apply intracanal medication in the canal? Larger size master cone or master apical file or something else?
All right. So thank you for your question. Uh, what I have commonly seen is that um, when I want, while applying, firstly, if you are using your ICM intracanal calcium hydroxide paste, the dispenser usually has a very thin nozzle in front, so that gets inserted in your root canal directly, and you can insert that and you can passively apply it. And once the canal is filled with intracanal medicament, what you can do is you can place your master cone, and you can just do a mechanical agitation with it. That is one aspect of it. If you are applying it with if you are manually mixing it, like the calcium hydroxide paste liquid, or you're mixing your Dexa and your chlorhexidine or whatsoever is on your paper pad, what you can do is you can gently pick it up from your master file and you can insert it. Always make sure not to go beyond the apex. Third, what I commonly have seen really good results with is when I agitate, or when I uh, agitate my intracanal medicament using endoactivator. That has given really good results for me, because that helps the intracanal medicament to flow in those isthmus and those accessory canals as well. So you can even agitate it with that. If you don't have these devices, you can just pick up your master cone and just manually agitate. But of course, keep it 1 mm short of your working length, because you don't want it to go beyond, or for the patient to feel that heaviness or that pain when you're inserting your ACM. Yeah, I think that answers.
Okay. Do you believe that glass being your files 20-30 seconds enough for sterilization, or is it autoclaving the files important?
Can you repeat the question?
Do you believe that the glass bearing your files 20-30 seconds enough for sterilization, or is it autoclaving the files important?
Uh, I personally believe that autoclaving is superior because I believe that maintaining your asepsis is it's not just about talking about flare-ups. It's just in general autoclaving your files, be it your endo files or be it your rotary or whichever file system you use. It is essential, and autoclaving it before every patient. That's something that just should be done, irrespective of you taking up a flare-up case or you taking up any case in general. Yeah, I hope that answers.
Okay. So, one of our participants have posted that one of their patients, after the obturation, also had pain. They reshaped it, they used medications, gave analgesics, deobturated, and left for weeks. Still, patient complained of severe pain. So, what should be done in such cases?
All right. So, first up is the first D of our 3D approach. As mentioned, that the patient, even after several weeks, was having pain. So, it does not qualify as a flare up case. This is a simple case of post-operative pain, or maybe it is multifactorial. For that, we need to check up on. There are 101 reasons why patient can have post-op pain, right? Which is not a flare-up. Flare-up is just one kind of post-op pain that happens. Since you mentioned it, it went on till weeks. It cannot be that. And you have taken an intervention. You have deobturated. You have re-instrumented. Maybe sometimes what happens, you can check for there might be a crack somewhere, which often happens, not on the coronal part of it, maybe somewhere around the furcation, maybe around somewhere around the systemus, there can be a crack. So I would always suggest, when you are not able to understand what's wrong with the tooth, why is it still hurting for the patient, after taking all the measures, you can go for a CBCT if already not done previously, because there is only so much that we can gather from a 2D scan. So always a CBCT works out really well, because even in my clinical practice, what I have observed is there have been cases where we were unable to understand why the patient was still having pain, even after deobturating or reducing occlusally, um, placing intracanal medicaments, placing a reliable temporary restoration, uh, reconfirming the working, everything, like everything that can be done for that particular tooth. Um, Still, the patient was complaining of pain. Again, very important to distinguish between discomfort and pain. That is something that I've seen patients don't really, they don't really differentiate well. So again, that is another thing. But yes, in such cases, CBCT can be really handy because it tells you what you cannot see with your 2D scans. Yeah, I hope that answers.
Okay. So, ma'am, after RCT, how much time will it take for the healing abscess completely to recover?
Okay, thank you for your question. This is, I would say, it's a little vague for me to answer, because healing abscess, again, I mean, to for you to observe changes on the radiograph, it takes the bone to regenerate and things to happen. It takes a minimum 3 to 4 months, so you can't wait till then. But what I try to say is, literature states that for you to say the tooth has been successfully RC treated, given that there are no symptoms, given that there is no pain, there is no periapical lesion increasing and stuff like that. So for that, you need to wait 4 years. That's what literature says. That only after 4 years are you in a state to call this RCT a success or a failure. That's how you decide. So in those 4 years, if pain occurs, if the periapical lesion is continuously increasing in size, or if patient is having any other symptom, tooth becomes mobile or whatsoever, basically any symptoms that occurs radiographically or clinically, it's a failed RCT. So what I would suggest is, take follow-up radiographs, keep the patient on follow-up, look out for any symptoms. ask the patient to report if there are any case, if there is any symptom, because a lot of factors influence the healing of the kind of abscess. Now, I don't know what kind of abscess you're talking about, right? So it's a lot of factors, play of a lot of factors. But from what I could understand from the question, I would say keep the patient on follow-up, and during that time, and for you to scientifically call it a success or a failure, the period of 4 years is required. Yeah, thank you. I think that answers.
Yes. So, Doctor, which-sided vented needles are best?
Uh, I didn't get the question. Can you repeat? There's a lag.
One of the questions are which side vented needles are the best?
See, the part where I have really given more emphasis on when it comes to flare-ups and keeping in mind this particular session is that the agenda. The agenda of having a needle which is side vented is that uh, you do not want the irrigant to touch or to go touch or get in direct contact with the apical part of the root, right, or the root canal. So side vented needles are always better. And when it comes to which one, I do not really have a comment on that. But yes, what I'm trying to say is, my agenda over here is to not let the irrigant go beyond the apex. Hence, I had suggested that we should go ahead with gentle irrigation and not a forceful, active, pressured irrigation, or for that matter, pushing of the intracanal medicament, or for that matter, pushing of the sealer. None of these agents should go beyond. Yeah, I think that answers.
Okay, one more. Can you please shed some light on apical puff?
Again, thank you so much for that question. A very interesting one. Again, heard a lot, talked about, read a lot on this one since the time we have known about apical puffs. If you ask my particular experience, because we can always read what the literature says. Again, not so clear literature statement over here with respect to that. If you accept it, reject it, again, it will fall under the controversial category. But what I believe, I accept apical puffs. I really believe that it is something that if it happens, I know for a fact that I have my irrigant has reached where it had to. My sealer or my agents, my cleaning and shaping, the process has been able to reach that banyan tree morphology of the root apex. So yes, I accept it, and I do propagate it. But again, it depends a lot on if you're, sometimes what happens if you want to do that really intentionally, you would end up going beyond the apex with that instrument of yours, and that leads to another set of complications. So obviously, it's always a game of weighing your pros and cons, because there's no clear cut scientific advice on whether you should go for it or not go for it. So again, but however, I like to go for an apical puff. It has always been supportive of the treatment that I do, and I have not seen any cases ending up in a flare up or ending up in a severe discomfort when it comes to apical puff. Also depends on the kind of sealer you're using. So yes, this is my take on that. Yeah, I hope that answers.
Participants, if you want to have more questions, kindly please drop it in the chat box. We'll be wrapping up the session in another 10 minutes. So with this, we come to the end of this webinar today. Thank you so much, Dr. Lochan, for such a valuable and insightful session. And thank you all the participants. Hope this webinar added practical clinical value to your everyday practice. Before we close, I kindly request you all to please fill out the feedback form. The link of that has been shared in the chat box. Your feedback is extremely important to us, and it helps us to improve our future learning sessions. We will be upcoming classes and courses under Smiledge Dental Education, so your feedback is really important. And to stay updated with our upcoming dental webinars, clinical events, and educational content, do follow and stay connected with Smiledge Dental Academy across our platforms. The links of that has been shared in the chat box. We have a WhatsApp Smiledge Dental Community, Instagram, LinkedIn. You can also directly contact Smiledge Dental on the contact number which has been mentioned. You can also be updated through our website. And we have launched a YouTube channel today with this webinar. So the live recorded session will be also uploaded on that shortly. Once again, thank you all for being a part of today's session. We look forward to welcoming you to many more learning experiences with the Smiledge Dental Education Academy. Also, a short announcement, which I've also shared in the chat box. There is an upcoming free hands-on program by Pidilite in collaboration with Smiledge Dental Academy that is upcoming in Bangalore on December 23rd. It is on the Lavelle Road, and it is between 2:30 p.m. to 5:30 p.m. The details of that has been shared in the chat box, and same will be also uploaded across the social media handles and the WhatsApp community. Once again, thank you all for being here. Have a great day ahead. Thank you so much. Please fill the feedback form. Thank you so much. Thank you, Dr. Lochan.
Thank you so much for having me.